So this is a recording of the flipped classroom session. It is not the actual flipped classroom session, as you had to be there in person. However, this is going over what was covered in that session without the interactive poll everywhere. The dog presented here as case 1. He's an older male border collie, and he was presented first to his vet because of reverse sneezing. And if you've never heard of reverse sneezing before, it's like a sneeze, but as the name implies, the sound sort of goes backwards. So it's like a kind of very loud, distressing snort. Very uncommon in border dogs, much more common with dogs with large, soft palates, long, soft palates, where it tends to sort of get caught up over the larynx. Was of obvious concern to the owner, but as the owner was a vet, thought it was maybe just one of those things. But what was more concerning was this dog then developed this atrophy of the temporalis muscle here. And you can see the outline of the skull here is normal, and we can see that this is loss of muscle here. It perhaps might be a little bit difficult to see, and because the dog is black, and one of the general rules about neurology is that if you have a dog with temporal muscle atrophy, it will invariably be black and won't photograph well. This is something that you would palpate. So you can also see an obvious problem with this dog's eye, and we're going to come back to that. The vet did an initial workup, was blood work, which is what the CBC and profile means, and that was all normal. They not sure, and there's no travel history. Knowing that there's no is quite important in this day of increased animals across borders, because quite a few nasty infections are now coming into Britain. So you do a neurological examination, and first you note that this dog is bright, friendly. This here starts for quiet, alert, and responsive. The gait was within normal limits. And you do a cranial nerve examination, you find there's atrophy of the right temporalis muscle. There's stringy saliva in the right side of the mouth. And there are these eye abnormalities. There's a myotic pupil on the right, and that means that the pupil is smaller than in comparison to the normal left side. There's protrusion of the third eyelid, and there's ptosis, so the eyelid is more closed, and enophthalmos, meaning the eye is more sunken on the right. And you do something called a Schirmer tear test, and this is an assessment for how much tears the dog is producing. And quite literally, you put these little bits of blotting paper into the eye, sort of goes in at this area here, and then the amount of tears that are produced gets soaked up onto this blotting paper, and there is a dye there. So how many tears there are gets measured on this strip. And you can see this particular animal here has quite an asymmetry between the eyes. And we have this only 11 here, which is borderline abnormal, and a dog that's producing nearly 20 millimeters here, which is normal. I would say that this dog is so borderline abnormal and also so asymmetrical that it's likely that there is a mild problem here. But in this dog, from which we're actually talking about, the Schirmer tear test is only 6 millimeters. So this is a definite dry eye, not producing enough tears. You then some postural reactions, and these are all normal. This stands for general proprioception and normal hopping test. And the reflexes, muscle tone, muscle bulk, no atrophy, and pain perception are all within normal limits for all 4 dogs. Sorry, all 4 limits. So the first question, which was asked on a poll everywhere, but you can answer yourself privately, is what are the differentials for unilateral temporal muscle atrophy? Primary muscle disease, trigeminal nerve lesion, facial nerve lesion, 1 and 2, 1 and 3, 1, 2 and 3. And I'm just going to take a moment there for you to have a think of that answer. So the correct answer for this is the trigeminal nerve lesion. So this is here. I'm trying to outline it, but it's not doing so. So I'm just going to go back to the laser pointer. So a trigeminal nerve lesion. It's not unusual. In fact, it's quite common that vets choose facial nerve lesion because they think this is the facial muscles. But the facial muscles are actually the muscles of a facial expression in humans. And if you think about the muscles that you would use to move your face, how you smile, you blink, you grimace, and keeping food in your mouth, these are all facial muscles. Instead, the muscles that you use, what I call the chewing gum muscles. If you think about yourself chewing gum, what muscles are contracting? These are the masticatory muscles, and that's the temporal muscle, the masticatory muscle, and the pterygoids behind. And these are all innervated by the trigeminal nerve. Now, you may have chosen a primary muscle disease, but it would be unusual in a primary muscle disease for it to be completely unilateral. Diseases where there may be some asymmetry. So if you had chosen 1 and 2, I might kind of accept that. But typically, muscle disease will involve both sides, as we can see in this Wiesler here, that has an autoimmune disease against the muscle, loss of both the temporalis muscle and the masticatory muscle on both sides. So you also notice that this dog with primary muscle disease has its jaw shut. So despite losing all of this muscle, it still has pretty normal jaw tone. And we assess jaw tone, as we're doing in this cat over here, by trying to open the mouth. You can see in this particular cat, I'm trying not to put my hands in the cat's mouth. If a dog normal muscle tone, then, or a cat, you can open the jaw far too easily. And you can see in this little puppy here, actually she's quite an old dog, you're going to see quite a few videos of this, and I have to give a sort of disclosure here, is this was a very friendly dog. I wasn't torturing it. She's having a lot of treats, and that is explaining some of her actions, such as her excessive licking. So the masticatory muscles, the temporalis and the pterygoids are the muscles that we're talking about here. Because of the dog's skull shape, it's often the temporalis that you notice the most. So bilateral trigeminal nerve palsy, then we have difficulty in closing the mouth. And such is shown in this dog with a bilateral trigeminal nerve palsy, it's keeping its mouth open. Actually, this is quite an acute lesion in this dog's case, and so we can see actually this dog has not yet lost that muscle. It will do so, though, over the next couple of weeks. Here is our little Jack Russell again, and you can see that she is also having difficulty closing her mouth, and she has dysphagia. She has difficulty picking up those treats that she's been given by my assistant. She keeps lifting her paw, by the way, because she's been told, practicing her high five, which is what she was using to get treats from her own. You see, it's very difficult for her to pick up these little biscuits that she's getting. She also has quite uncoordinated head movements with that sort of slight head wobble because of a cerebellar disease. I think looking at a scan of the tumour of a nerve, a cranial nerve, can help you with your anatomy. I always found it was very difficult to understand the anatomy of the trigeminal nerve. And this is a trigeminal nerve root tumour. This is an MRI scan. You have to think about an MRI as being like a loaf of bread and taking out slices. So this is a slice in the transverse plane. And the normal trigeminal nerve is here. You can barely see it. And all of this blue arrowed area here, this big lump is a trigeminal nerve root tumour, and the ophthalmic branch comes rostrally under the brain at the skull base, and it goes forward through the alar canal here, and you can see it going forward here towards the eye. I think the other thing that this image really shows is the dramatic muscle atrophy. So we have the outline of the skull here, and the temporalis muscle here, and the masticatory muscle here, and we can see that it's absent on this side, highlighted by the green arrow. So my next question was that if you were concerned about the trigeminal motor function, what would be the most important test to do next if you could only choose one test? And of course, you would do all of these if you were doing a neurological exam. Would it be to assess if the tongue is moving normally, to assess if the muscles of facial expression move normally, to assess if facial sensation is normal, to assess if there's a gag reflex, or to assess if there is a head tilt? I'm just going to take a moment so you can think about that. And the answer is to assess if facial sensation is normal. And the reason why that is the most important is because that is the other arm of the trigeminal nerve. So the trigeminal, which we've already established as having a problem with the masticatory muscles, and the motor also does sensation to the face. And this is where many people can get confused, because they think that it would be more logical perhaps if sensation to the face was the same nerve as the muscles that move the face, but it's not. It is the trigeminal nerve, and the trigeminal nerve is of course named because it has three branches, the ophthalmic, the maxillary, and the mandibular, and you need to assess all of those. And the tests that you use are the palpebral reflex, where you touch the commissures of the eye and we should see a blink, the corneal reflex, where we touch the eye and either see a blink or a pain response if the animal is unable to blink, and of course sensation of the head, so ear, lip and nose. That allows us to assess the three branches. So we tickle in the hair of the ear, we tickle the whiskers, and we tickle inside the nose. So as we can see in this cat here. And of course, this is a reflex. So we're looking at the sensation, which is trigeminal, and the movement, which is the facial nerve. So to be able to tell this cat can feel, we either have to see a behavioral response, such as shaking the head, or we need to see the movement of the muscles, the eye closure. Here we can see our little chap, and she fails to close her eyes. We can put these probe straight in her nostril. She's licking a lot, again, because of the treats, I'm afraid. And we really have to give her a very, very painful pain stimulus, which is clamping the lip there, and she still isn't reacting. However, if we do a dazzle reflex, shine a very bright light in her eye, we can see that her eye, as a protective reflex, does close. So this dog is actually able to move her eyelids. She has some facial nerve function. And this tells us that this is predominantly a trigeminal lesion. She didn't have a menace response because of a cerebellar problem, which I mentioned before, and we're going to come back to with another case. So, going back to our original dog, we've now established that it has likely a trigeminal motor lesion. We're not going to comment about the facial sensation at the moment, but we did test this. What, however, is the interpretation of this eye appearance, which is, to go back, is the myotic pupil, protrusion of the third eyelid, anatosis of the eyelid, a droopy eyelid, and sunken eye, which is enophthalmos. Is it an iris spasm secondary to corneal ulceration? Is it a Horner syndrome, facial nerve paralysis, or a cherry eye. A cherry eye is where you have an enlarged, sort of prolapsed third eyelid. And I'm going to give you a minute for that. So in actual fact, many of these could result in that appearance, but the one that consists is a Horner syndrome. And what a Horner is a lack of sympathetic supply to the eye, as shown in this eye here. The sympathetic supply to the eye coming in this diagram here from the spinal cord segments of T1 to T4 coming up to the cranial cervical ganglion, and then off it pops to the eye and to the blood vessels, and the salivary glands. Often these eyes also look quite red because of dilation of the blood vessels. The way to remember a Horner syndrome is the opposite of a fight or flight response. So if you had a fight or flight, your eyes would be bulging, perhaps, with dilated pupils, so that you're able to see as well as possible. This is the opposite to that. So meiosis, this pupil is smaller, although it's difficult to see because the eye is so sunken, with the third eyelid protruded, with a narrow palpebral aperture. So I showed you a more complicated anatomical diagram, but this is the simple cartoon because I'm a kind of simple person. So the sympathetic supply to the entire body comes from the hypothalamus, and it trundles on down the center of the brainstem near to the very central grey matter, which is called the periaqueductal grey matter. It's in the intermediate grey matter, and down the spinal cord thereupon it has a synapse, and then it exits. Most of the sympathetic supply continues down the sympathetic chain, but the stuff innervating the head comes up the vagus sympathetic. Another synapse trundles off through the middle ear, back in through the skull, where it travels with the trigeminal nerve. And the important thing is that you should remember that when we do a neurological examination, we're not trying than they already are. We try to find a localization that is one lesion that can explain all of the signs. And so if we have a trigeminal nerve problem, then it makes more sense that the sympathetic supply is affected here. We could use some other testing to help support that. We can apply phenylephrine, which is, as the name implies, epinephrine is adrenaline. So we can apply a sympathetomimetic, as it's called, directly to the eye. And then the eye is super sensitive and dilates. And it becomes more sensitive the closer to the eye the lesion is, and that's because of a phenomenon called denervation. So this is something you'll come back to in later years, so no need to really concentrate on it too much. But if the eye is lesion is very close to the eye, as would be in this case, then we'd expect that dilation to reverse within 20 minutes. It's only a temporary dilatation, I should say. If it is in the area of the vagus sympathetic trunk, then it would take slightly longer. And if it is in the area of the spinal cord or the hypothalamus, then it's more than 40 minutes, or it might not change at all. So that's one little test that you can be doing in practice to help confirm your local. This is a more complicated diagram, but it's really to show that we have the trigeminal nerve coming off here, and that the sympathetic supply to the eye travels with that trigeminal nerve going, which is now referred to as the long ciliary nerve, and it's traveling with that nerve, also in the same foramen as the parasympathetic supply, going to the orbit. So my next question is, what is the explanation, the neurolocalization of the dry eye? Is it a lesion of the parasympathetic branch of the facial nerve, the parasympathetic branch of the trigeminal nerve? Poor technique because of the ptosis. It actually can be quite difficult to get these in if the eye is closed. Or reduced tear production because of the ptosis, giving you a few seconds there. So the answer is actually, and perhaps quite surprisingly, lesion of the parasympathetic branch of the facial nerve. Now, at this point, you may be wanting to get up and leave with the complex neurology. However, there is a point for telling you through this complex collection, which I'll explain in the next slide. Reduced tear production because of this could be, or report technique. Yes, this could be a possibility. Parasympathetic branch of the trigeminal nerve. So, facial nerve, its supply from the facial nerve actually travels with the trigeminal nerve. So nerves all traveling in a bundle together, and when you have one affected, especially the trigeminal nerve, it's common for the others to be affected. Why is that important? Well, the reason is the lacrimal gland is producing tears to protect the eye. The trigeminal nerve also protects the eye because it receives information about nociception or pain. So if the eye is being traumatized, perhaps because it's too dry, then the trigeminal nerve will be activated and the eye will close. But this dog has no functioning trigeminal nerve in that region, and therefore, and no tears. And this is how these eyes get really damaged really quick. So the point of telling you this is not to confuse you with anatomy, but to warn you that if you ever see this in practice, you need to check the tear production, and more importantly, just assume it's bad and then give the dog artificial tears. Because if this little branch gets affected alongside here, there's enough space occupying lesion, then the dog could literally rupture their eyeball. And once that's happened, there's nothing you can do about it apart from refer it to an ophthalmologist or remove the eye. Oh, the neuroanatomical localization for this dog was the right mandibular branch of the trigeminal nerve going to the temporalis muscle, plus the ophthalmic branch because of the neurogenic conjunctivitis sicca, and we also had a Horner syndrome. An MRI scan was done, and much like that other image that I showed you, we in the area of the trigeminal nerve here. This is the abnormal nerve here, and this is the more normal side, and we can see the muscle atrophy on that side as well. This is another section showing again the masses around the ophthalmic and the maxillary. And this is the mandibular branch leading here, it's medial to the tympanic bulla. So I want to show you another case. This is a Staffordshire Bull Terrier where the owner had noticed an abnormal right ear position and a tendency to drawl coming out of the right side. And you can notice here how asymmetrical the face is. So we have the lips drawn up this side and hanging down this side. So if I just show you the video on this. So as you can see, we again have an absent palpebral reflex on this right side. But when I do a corneal reflex, can you see that the eyelid, third eyelid, is coming across? There is our drawl coming down, just tickling the side of the mouth. It's a very stoic dog. You can see it doesn't really like me doing that, even though it's only just a very light touch. It doesn't like me doing in the ear. And much more sensitive, really doesn't like me doing in the nostril. Whereas when I compare it to the other side, we can see that the eye is shutting. The ear is moving when I do that. Doesn't like that. But when I do that, can you see that the lip was retracted back just there? So we can see normal facial movement on the left side. So my question here is, what is the problem? Is there a facial nerve paralysis, an oculomotor nerve paralysis, or abducens paralysis? This is another dog with exactly the same thing. And I'd just like you to show you that, see there, that flick up of the third eyelid, showing that there is some sensation or visual response to the menace that she's doing. She's doing a palpebral and a menace, and you see that third eyelid flick. And that's very important for distinguishing this particular type of paralysis. So the answer to this is that it is a facial nerve paralysis. So we have paralysis of the muscles of facial expression. We can't close the eye. Sensation is normal because when we touch the lateral canthus, we get that abducens nerve pulling back the eye and the third eyelid flicking up. The oculomotor nerve is the nerve which moves the eye both internally and externally. So we need to tell the difference between central and peripheral facial nerve paralysis because this is common situations that you'll have in practice. And the way we do this, central meaning brain, is assessed by the dog's mentation, but also the postural responses.
Yes.
See that we're assessing proprioception here. And it's very difficult to knuckle over this dog's foot. She won't let you, suggesting she has normal sense of where her feet are in space.
Okay, now hop those legs, please. Excellent.
That's a normal hopping response there. Normal there. And this is a peripheral facial nerve paralysis. It's an idiopathic facial paralysis, which is common in this breed, middle-aged Staffordshire Bull Terrier, and also boxers and spaniels of all types. And this will get better spontaneously. Sometimes you can speed up the recovery if you're seeing them in the very acute phase, and by very acute phase, I mean within 72 hours, by steroids. The point of doing this, showing you these lesions, is this is very much a benign condition. It's also called Bell's palsy in humans. This is not a brain tumor. This is a peripheral problem and therefore has a good prognosis.
Yes.
So going back to our border collie up there, this dog was managed conservatively. Yes, we've diagnosed a brain tumour, but there's no need to put the dog to sleep as yet. And he comes back in. This is another vet's dog. He's got some eye lubricant as well. And the owner reports gagging with drinking and a soft cough. This particular clinical sign is very important sign of perhaps having a laryngeal paralysis, because the larynx isn't closing properly when you're drinking. And they do some repeat radiographs, but they notice that there is a megaesophagus there. So this outline here is showing the outline of the esophagus, and normally the esophagus appears a bit like this vessel here. You can sometimes barely see it. It looks like a muscular tube. When it's paralyzed, or when there's muscle disease, it becomes this great big flaccid disease, and in many instances the dog will be regurgitating with that problem because of an inability to swallow. Neurological exam. The pupils are now symmetrical, which is a bit unusual. The Horner syndrome must be affected by the steroids. The third eyelid, however, is still elevated. There's still the atrophy of the temporalis muscles. There's still the thick saliva. This may be due to either an effect of the autonomic nervous system on the salivary glands, or possibly an effect of failure to swallow it. But we're now seeing an atrophy of the right side of the tongue and reduced movement of the right arytenoid cartilage at the time of intubation. Postural reactions are still within normal limits, and spinal reflexes, limb muscle and tone, etc. was all within normal limits. So our tongue. For those observant amongst you will notice this is a different dog. So we can see the atrophy of the tongue here. And when I just start this video here, we can also look at the larynx. Now the larynx is right down the bottom, as that's a dark slit. And what you can't hear so well here is there is a nurse going in, in, and what the nurse is doing is telling the vet when the dog is breathing in. And when the dog is breathing in, then that arytenoid cartilage should open up. You should see that little dark slit at the bottom become much, much wider. And this is because this dog has bilateral laryngeal paralysis, and it's not uncommon for the larynx to become have a paralysis in older dogs. It's one of the longest nerves in the body because it comes all the way down from the brainstem, loops around the heart and comes back up again. And so it's commonly affected in polyneuropathies. In this dog, however, it was only one side. In our dog case example, it was only one side, and I don't have video of that, unfortunately. Is what cranial nerves are involved now? Is it the vestibular cochlea, the glossopharyngeal, the vagus, the accessory, or the hypoglossal? So the answer is actually multiple ones. It is importantly, however, the vagus, which innervates the larynx, thus resulting in that failure to move the anteronoid, the vocal folds out the way, and also the soft cough and gagging whilst you're eating because food gets caught around the larynx, and also the hypoglossal, which is the motor to the tongue, but only on one side. It's likely the accessory is affected as well, because applies additional fibers here. Glossopharyngeal is the gag reflex, which we would need to assess in this dog, and vestibulocochlear is the vestibular nerve and the hearing nerve, and there's no evidence that it's affected. So this dog has a right mandibular branch of the trigeminal nerve. We know this already. Ophthalmic branch as well, with neurogenic dry eye, Horner syndrome, plus right vagus nerve and right hypoglossal nerve. It's just taking its and now it wants to go back. So it needs to go back one slide just here, but it doesn't want to. Okay, we're just going to look at this, and I'll see if I can get that slide to go back in a minute. So basically, this is the base of the skull, and this is the jugular foramen, and those nerves, the vagus, the accessory, and the hypoglossal, are coming out at this region. This is the abnormal side in that particular dog. I've got to go backwards. So we will have to look at a different image, I think. Which is this one. So what we're seeing here is the spinal branch of the accessory nerve, and this is the junction of the skull and the vertebral columns. This is the first part of the atlas. This is the brainstem. This is the cerebellum. This is the slice directly behind. So we can see this tumor is involving the accessory nerve, and this is the vagus that is running just below the atlas at this point. Slides are moving very slowly at the moment, but I don't click on them too many times, otherwise this again is showing this tumor now that is right involving on the right side of the spinal cord. We're kind of assuming that is involving the accessory nerve, maybe something else, and we have the vagus there. Here are the slides that we missed, so never fear. This is the one showing the hypoglossal, vagus, and accessory coming through the jugular foramen, which is here. Now that nerve has been removed, and then the vagus comes down in this region here, and we can see it there, 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 and there. And just to give you a bit of anatomy, this is the atlas here, this is the tympanic bulla here, and this is the occipital condyles here, and that's the space between the skull and the neck there. So just try to orientate you where that anatomy is. Really slow. So this is the transverse section through that dog's larynx, and you can now see the muscle atrophy of the cricoarentenoid dorsalis. A little thinner on the than on the left. On the right side it had the problem, and this is where the section was taken right there. So what was wrong with this dog? Well, it had a neoplastic infiltrate into multiple cranial nerves through the perineal sheath, and this is quite characteristic. This kind of ring-like appearance of all these little blue cells here is quite consistent with a carcinoma. We didn't know which carcinoma was, and it was probably a salivary gland. So that concludes the first flipped classroom session, which was dealing with the cranial nerves. The next session is dealing with other parts of the neurological exam.